Okay, good morning everyone. My name is Leong. I'll be presenting the CME today, titled Acute Stroke Protocol. So basically, I'll be talking about stroke and what's our role in ED in managing stroke. Okay, so the definition of stroke, basically it's a loss of cerebral function, whether it's focal, global, and the range of symptoms can be more than 24 hours, and the worst at the end of the spectrum can lead to death, and it's caused by vascular origin. So it can also be classified based on the different timing. We have our early and late hyperacute stroke, which is less than 6 hours and 6 to 24 hours. If it's within 1 week, then it's acute stroke. More than 1 week to 2 weeks, more than that, it's chronic. Next, regarding TIA, transient ischemic attack. Before that, we use a time-based definition where the symptom resolves by itself within less than 24 hours. But now we are using a new definition, which is tissue-based, because it is thought that although the symptoms resolve within 24 hours, but there's a risk of permanent injury. So now the tissue-based symptom doesn't involve, there's no time limit for the symptom resolution. It's just mentioning there's a dysfunction caused by ischemia, but there's no acute infarction. So when, let's say, the patient presents with a TIA, what we can do to stratify the risk, we have 2 scores. We have ABCD2 scoring system, and there's another one, ABCD3 I score with an addition of imaging. So the first one, ABCD score, let us know the risk of the stroke following the TIA. So we take a read, age, blood pressure, the symptoms of TIA, whether there's one-sided weakness with or without the speed, and the duration of TIA. So as you can see on the right side, then there's different risk category, 0 to 3, 4 to 5, and then 6 to 7. ABCD3 I score, there's an addition of imaging, and we also take into account whether there's a preceding TIA episode within the within the previous 7 days. So stroke can be divided into ischemic and hemorrhagic subdivided into intra-parenchymal bleed and also subarachnoid hemorrhage. There are modifiable and non-modifiable risk factors, with the most common one being hypertension, DM, smoking, hyperlipidemia, IHD, atrial fibrillation. Non-modifiable includes age, sex, and also family history. So for the pathogenesis of the stroke, first we go to the ischemic stroke. Usually there's clot formation over the heart. Over here, there's clot formation in the heart, and then the clot can travel up to the brain, causing a vessel occlusion and lead to ischemia. If it's not a clot formation, there can be a atherosclerotic plaque either in the ICA or within the cerebral vessel itself. So if it's in the ICA, the plaque can be dislodged and also travel out. For the hemorrhage part, it can be classified into traumatic and non-traumatic causes. So non-traumatic causes most commonly by hypertension, chronic hypertension, which can lead to the microaneurysm of your small arteries. And if it's traumatic, then the cause is obvious. So identifying stroke. So in our pre-hospital care, we are using Cincinnati pre-hospital stroke scale with the mnemonic of either fast or be fast. Once the patient is in ED, then we use Gaussian recognition of stroke in ER. So rapid recognition is important because we want to make sure we can identify stroke within the thrombolysis period, which is 4.5 hours within onset. So this is the BFAST mnemonic used in pre-hospital care. So your balance, whether the patient has loss of balance, blurred vision, facial asymmetry, one unilateral weakness, slur speech, time is just to remind us that duration must be fast in picking up stroke. Once the patient is in ED, we use Rossier score, which lets us differentiate whether this is a stroke or a stroke limit. So if the patient has LOC, syncope, or there's any seizure, that's actually less likely to be stroke. But if there's any similar features, facial asymmetry, arm weakness, leg weakness, slow speech, then stroke is likely. So there are a few different stroke limits to be keep in mind. So metabolic causes, we have your hypoglycemia, your encephalopathy, infectious causes, your Bell's palsy, your CNS abscess, neurological causes, seizures, brain tumor, TBI, and toxins. So the signs and symptoms, of course, depends on where is the patient, which lobe is affecting. So if it's a wake-up stroke, where we are unsure when is the exact onset, so perfusion scan might be helpful to detect the penumbra and also the infarcted area. So infarct, there's two things. Infarct pop basically means the area that has died off that we couldn't salvage. What we are interested in is the penumbra area, which is patient the brain tissue that is ischemic but has not yet infarcted. This is potentially salvageable, and we can detect this through perfusion scan. Okay, I'll move on with the arterial supply of the brain. So the cerebral supply, 80% of it is through your ICA, your internal carotid. That's your anterior circulation. The posterior circulation is your vertebral basilar system. So from the branch of the aorta, we have your common carotid artery, which branch into your internal carotid, which travels upwards to give our anterior cerebral and also medial cerebral. For the posterior system, we have our vertebral artery, which first branches from subclavian. It travels upwards into the transverse foramina from your C6 to C1, and then it enters the foramen magnum. Two of the paired vertebral artery will combine to form the basilar artery. So it can also be divided into four parts of vertebral artery. So the first part is pre-foraminal, before it enters the transverse foramen. The second part is foraminal, when it's transversing through the foramen. Then after it exits through, the third part is the extradural. Last one, when it enters foramen magnum, is the intracranial part of the vertebral artery. So from the ICA, it gives off medial cerebral artery, or MCA, and ACA. So there is anterior communicating artery linking between the two. While from the MCA, there's posterior communicating artery linking the MCA to the PCA. So this forms a circle of release. And for the blood supply, we have three: anterior, medial, posterior. Anterior maybe supply the medial section, the frontal lobe, parietal lobe, but it's the medial aspect of it. The lateral aspect, your lateral parietal temporal lobe, that's supplied by our medial cerebrum. It also gives off small branches, lenticular-striate branches, to supply basal ganglia. Posterior PCA supplies mainly at the posterior aspect, which has occipital lobe and our occipital lobe, cerebellum, brainstem. So these motor and sensory homunculus basically let us know which area of the brain corresponds to which area in the body. So we can remember it as an inverted person. We can remember the homunculus as an inverted person with the head at the bottom, and then the body, and then the legs. So with this homunculus, we can differentiate between the anterior and also the medial. As we can see, the anterior cerebral artery supply mainly the medial aspect. Supply the medial aspect, so the legs will be more affected compared to the face, body, and also hand. But in your MCA, it mainly affects the lateral aspect of the brain. So your face and upper lobes will be more affected compared to your lower limb. So we have this anterior circulation stroke and posterior circulation stroke. Besides the area affected from the motor and sensory deficit, we have other features. So in your MCA, we can also have aphasia when the dominant hemisphere is affected. We can have homonymous hemianopia, parietal lobe dysfunction. In posterior cerebral artery, because of the cerebellum and occipital lobe is affected. Cerebellum and occipital lobe is affected, so many visual symptoms and symptoms affecting your motor, your balance. So patient will have ataxia, vertigo, diplopia, dysphagia, Horner syndrome. There's also this Oxford classification we can use to help us determine whether this is an anterior circulation involving a total involvement, total occlusion, or partial, posterior circulation syndrome, or it's just a small branches, lacunar syndrome. So for your anterior circulation, there are 3 clinical features. If all 3 are present, then we can classify it as total anterior circulation syndrome. But it's only if it's only 2, then we call it partial. So among the 3, you have your hemiparesis, your higher cortical dysfunction, and your visual symptoms, homonymous hemianopia. If it's posterior circulation syndrome, then it's an isolated hemianopia and other cerebellar syndromes like ataxia, vertigo, nystagmus. For lacunar syndrome, because it is small branches, so patient might only present with pure motor stroke, pure sensory symptoms. Next, I'll move on to the management of stroke and what's our goal. Basically, what we need to do is rapid recognition of stroke and then rapid activation of the stroke team. So patient will not miss the thrombolytic window. So starting from our pre-hospital care, using the Cincinnati pre-hospital stroke scale, with the fast mnemonics, we can have rapid recognition of stroke. And before even sending patient to the hospital, they should notify us, the ED staff on the floor. So we are on standby to activate the stroke team. This is basically the flow chart. So rapid identification of stroke within onset less than 4.5 hours. Once the patient arrives, depending on whether the patient is stable or unstable, we can triage to resusc or yellow. And after initial stabilization, we need to activate the stroke team. We call operator, activate stroke team, call radio, Centigrade. Following that, then the stroke team will work together with radio team to for further assessment, NIH score, and reviewing the Centigrade imaging, whether to proceed with thrombolysis or not. So this is the pathway in Sungai. So as I said, whether patient is stable or unstable, we triage to red zone or yellow zone accordingly. Following that, depending on the onset, we proceed with Centigrade. If there's no Centigrade, if there's no ICD, then we can proceed with CTA or perfusion scan. So if the onset is less than 4.5 and patient has no contraindication for thrombolysis, then we proceed with thrombolysis. And if there is a large vessel occlusion detected during CT angio, then we might decide for thrombectomy with the interventional radiologist. If it's more than 4.5 hours, but still less than 6 hours, depending on whether if there's large vessel occlusion, we still proceed with thrombectomy. So if the patient come late, more than 6 hours, then it will depend on the perfusion imaging. This is relating to the penumbra versus infarct form. Although the patient has missed the thrombolytic window of 4.5 hours, But depending on the perfusion imaging, if we can determine there's still penumbra, there's still salvageable tissue, we might still proceed. And of course, if non-curable, then there's only medical management. So this is to let everyone know we have a stroke bag located in our ED. It's placed above the shelf here at the back, the medication room. This is our stroke bag and research. So the contents, basically we have, besides the usual things, the syringe, the cannula, what's more important is the LT place, and also there's a file here to guide us. So inside this file, this is the similar workflow just now. What's the role of our ED team, stroke team, and also radio team? There's also some forms to guide us. This is for the pre-hospital care, the fast mnemonics. And our ED, what we have to do is fill up this. This is similar to the Rosier. Besides that, there's also binders. Okay. This is the flow. Again, it's the same thing. Call operator, activate stroke team, call radio for Centigrade. This is the output phase. Inside this one box, we have 100 milligram of output phase and also 100 ml of sterile water with 2 transfer devices. Okay. There's also this dosage calculator to help you. So what you do is you pull from the left side here until the patient's body weight, the correct patient's body weight is here. Once the body weight is correct, then you can read the reading for total dose, the bolus, and also the maintenance. But without this calculator, of course, you can calculate it manually, 0.9 milligram per kg, maximum of 90 milligrams. So the bolus dose will be given within 1 minute, or the rest will be given within 1 hour. So how do we mix the altitudes? So first you take the sterile water, you put in the transfer cannula. On top of the transfer cannula, you will put in the valve for altiplace. Once everything is done, you just simply invert it. So the water will be mixed into altiplace. Gently swirl the valve, make sure not to do it manually. Okay, then it's done. Make sure there's no air bubbles. Okay, there's this NIHSS score, National Institutes of Health Stroke Scale. So this is the 11 items for us to score. Basically, let us know how severe is the stroke. And if we take an NIHSS of 4 to 25, if it's too minor, then or it's too severe, then there's no patient is not a good candidate for thrombolysis. It also can predict patient outcome. If it's more than 60, then it's worse outcome. So there's 11 components, each score between 0 to 4. Higher score means higher level of impairment. So there are a few things. Make sure not to, when doing the score, make sure you don't help the patient. But what you can do is you can guide them to the starting position, but after that, they have to be by their own effort. Always take the first attempt, except for item 9, which is best language. For this one, there will be a few random words, random sentences, images that the patient has to read or describe. All this is also in the file in the stroke bag. The images and all is also in this file. Okay, move on to the general management. So of course, go through our ABCDE. Make sure that oxygenation is, make sure airway is vacant, make sure oxygenation supplement is adequate, our vitals monitoring, GCS chart. In terms of BP control, from the CPG guideline, we don't treat hypertension unless the BP is more than 220 and 120. But if patient is eligible for thrombolysis, we actually want to bring down the BP to less than 105 over 110. Because any higher than that will be contraindicated for thrombolysis. DXT is important as well. The cutoff is the contraindicated cutoff is actually 2.7 to 32 for thrombolysis. Prevent hypothermia because it's noted that fever, even if through inflammatory response and stroke, this actually has adverse outcome. Prevention of DVT, okay. Okay, bedside test, make sure we remember to do an ECG and DXT because they are also stroke mimic. Hypoglycemia can be stroke mimic. ECG for any cardiac arrhythmia because they can be cardioembolic in nature. Maybe arrhythmia is predisposed to clot formation, and which can travel up to your brain. So your basic blood investigation, MBC, we want to know if there's any anemia, thrombocytopenia. Again, low platelet count is also contraindicated, platelet less than 100K. RP electrolyte, hydration and electrolyte imbalance. Coagulation profile, first for a baseline, and if the INR is too high, more than 1.7, it's also contraindicated. So move on to radiology, your chest X-ray, your CT brain. If there is no ICB, there's no bleeding, you should move on to CT angio and CT perfusion. Okay, next, CT finding. Firstly, for the hemorrhage, there can be two types of hemorrhage. One is within the brain, intracerebral hemorrhage. Within intracerebral, the bleeding can occur within the parenchyma, so intraparenchyma, or there's extension to the ventricle, so intraventricular. The first one is showing intracerebral hemorrhage. Second one, subarachnoid, where it's bleeding outside the brain tissue between your PR and arachnoid matter. There are a few signs to let us know early infarction in MCA stroke. So for our dense, first sign is dense MCA sign, which indicates a thrombus in the MCA. There's a variation of that called a dot sign, it's similar, but instead of a line, it's just a single dot. This indicates the thrombus might be more distal in the MCA branches. Loss of insular ribbon. So because MCA also supplies the insular cortex. So as you can see, when compared to the other side, we couldn't see the insular ribbon, loss of insular ribbon. Here, this is the normal insular cortex, but this is the site of infarction. Okay. Sulfur effacement and also loss of gray-white matter differentiation, as you can see here and also here. This is because in infarction, there will be mass impact pushing on your brain parenchyma. So all that CSF will be displaced from the sulcus. Okay. This is a bit more subtle. There's basal ganglia asymmetry. When comparing both sides, you can see one side, it's harder to differentiate, to delineate the basal ganglia. Also due to blurring of gray-white matter interface and hypoattenuation. Okay, through the imaging, there's also this aspect score, Alberta stroke program, early CT score. So we start off with 10 points. For each region that there is infarction, we minus 1 point. So less than 7, we predict a worse outcome. So these are the 10 regions that we see when scoring this aspect. We have your caudate, internal capsule, lentiform nucleus, insular cortex, and M1, M2, M3 up to M6. Okay, next, specific management. So what our goal in stroke management is for early reperfusion, which can be done through thrombolysis or endovascular thrombectomy. So these are the two drugs that can be used in thrombolysis. Altiplase, as we have discussed just now, and the second option of tenecteplase with 0.25 milligram per kg, maximum dose of 35. So requirement, of course, we need a stroke team, we need imaging, CT angio, perfusion scan, and we need a place to manage the complication, usually bleeding or angioedema. So for the candidate, patient must be within the thrombolytic window, 4.5 hours, If it's a wake-up stroke, then we couldn't determine the onset. Then we would base our decision through perfusion scan. Make sure there's no hemorrhage and no other contraindications. We have our absolute and relative contraindication. So the BP, DXT, whether patient is already on anticoagulant, either heparin, warfarin, whether patient has coagulopathy, iron more than 1.7, platelet less than 100K. Rest is relative contraindication, where there's injury within the previous 3 months, recent stroke, recent MI, bleeding tendency. Okay, so to control the BP to less than 185/110, this can be done either via labetalol or GTN if labetalol is contraindicated. We can give IV or we can start infusion and then taper accordingly. Same goes for GTN infusion. After thrombolysis, ideally patient is admitted to ICU or stroke unit for monitoring, at least up to 2 to 3 days. So during this period, what's important is for BP monitoring, every 15 minutes for 2 hours, every 30 minutes, 6 hours, and then subsequently hourly for the next 24 hours. Within the first 24 hours, make sure there's no anticoagulant or any heparin given to restore the patient compared to the baseline in a HSS, post 2 hours and 24 hours, and repeat the Centigrade after 24 hours. At the same time, of course, we keep patient NBM, we make sure that DXT is controlled. During this time, also avoid any NG tube, CBD, arterial puncture. Ideally, everything is done before the thrombolysis. So there are 2 main complications that we are worried about, bleeding and also angioedema. In the case of bleeding, stop alteplase immediately. If there's new neurological deficit, then go for Centigrade. We can control the BP, give cryoprecipitate, IV platelet. In severe cases, we can proceed with tranexamic acid or recombinant factor 7. If it's angioedema, we also stop the alteplase, make sure airway is patent. We can give diphenhydramine and ranitidine. If it's not improved, we can proceed with metalprep. Still not improved, we can go for subcut epinephrine on that. Besides thrombolysis, there's also option of thrombectomy, usually in cases of large vessel occlusion, detected through the vascular imaging. So this is done by IR under sedation. There will be a catheter passed through either through your internal carotid or femoral artery. So you can see from the pictures here, they will guide the guide wire passing through over the clot to the other side. Then from the guide wire, they can pass through another wire with the stent, open up the stent, push it back, hold the thrombus within there's another proximal balloon cuff, hold the thrombus, and guide it out through suction. So when retrieval of the clot, there will be suction applied and balloon occlusion to prevent any embolization. And so these are the 2 pre-perfusion strategies we have, thrombolysis and also thrombectomy. Okay, that concludes my CME presentation. My references are from Idinali CPG and our hospital, Sungai Buloh, Acute Ischemic Stroke, 2nd edition. Thank you.
Thank you, Leong and team. Okay, do you have any questions from the floor?
Yes, boss. Just adding on. Okay, so very good morning. So thank you, Leong, for the presentation. So basically, I'm just adding on a little bit more on whatever has been presented by Leong. So first of all, this slide, the first one is on the choice of antihypertensive. I think based on what Leong presented, he already mentioned about labetalol and GTN. but I just like to mention a few more that we can use in treating high blood pressure in patients with acute ischemic stroke. So when do we treat? We don't treat all patients with high blood pressure with antihypertensives, only if the blood pressure systolic above 220 and diastolic 120, or if let's say we are planning to thrombolize this patient, that's when we use these antihypertensives. So besides labetalol, we can use nicardipine. The dose is 5 milligrams per hour. We can titrate up with the desired effect every 5 to 15 minutes to a maximum of 15 milligrams per hour. Or another option that would be is a nitroprusside. So this one is usually in the ICU setting. When this one, the dose is 0.5 microgram per kg minimum infusion with a maximum of 8 mics per kg per minute. Okay, so this is from CPG guideline, the one on the left. On the right side, I got it from Tintinali's the latest 9th edition. So besides labetalol and nicardipine, the one more option that they have is cladribine. It's the same group as the nicardipine. So that one, the infusion rate is about 1 to 2 milligrams per hour. And we can titrate every 2 to 5 minutes to a maximum of 21 milligrams per hour. So what are the side effects of these medicines? So for labetalol, we have to be, it may cause dizziness or nausea in patients if we are using a labetalol. So just watch out for those kind of side effects, and make sure to ask their comorbids as well. So those patients with severe asthma, COPD, or even those who have history of myasthenia gravis and all that. So make sure this labetalol, we have to really be cautious in using it because this may exacerbate the symptoms that we have already had before this. So make sure to ask all these comorbids before serving this labetalol. So for nicardipine, the side effects, it can cause a headache. Just go down. Okay, all right. So it can cause headache, flushing or dizziness, or even reflex tachycardia. And again, these patients, be cautious if you use in patients with history of MI or congestive heart failure or any hepatic or renal insufficiency. Okay, for cladribine, it's more or less the same. It can also cause reflex tachycardia as well, and be cautious as well in patients with comorbids like congestive heart failure and so on. Okay. All right, so for the imaging, Leong already explained there were a few that he mentioned, such as CT perfusion, CT brain, of course, and chest X-ray and all. But we do have other modalities besides this. So what are the other modalities that we have? We have MRI as well, but again, this is very limited settings. We have to bear the cost and all that. So usually this is only useful for patients where we plan for revascularization available, then we can consider using this MRI. And we can also use carotid duplex ultrasound. This one is basically those patients that we suspect of having some intracarotid stenosis and all that, something to do with extracranial vessel disease. This duplex ultrasound may help us to identify those things. Okay. Besides that, we also have MRA and MRV, which basically stands for MR angiography and MR venography. So MR venography we can use for those patients that suspect of having cerebral venous thrombosis. And for the MRA, it's basically a non-invasive tool as well. So this one we can assess both the intra as well as the extra cerebral circulation. Okay. Okay. So these are the few ones. So whatever these CT brains always comes first. The rest, it all we have to liaise with the primary team neuromeds and the radiologists as well. Okay. So for thrombectomy, basically based on American Stroke Association, they have these few indications before we decide whether this patient actually meets all these criteria for them to be eligible for this endovascular therapy. So they have this American Stroke Association have these 7 criteria that needs to be met. First is the pre-stroke modified ranking scale score has to be 0 to 1. That's the first requirement. And secondly, these patients with acute ischemic stroke should be receiving this RTPA within 4.5 hours of onset, according to the guidelines set by the professional medical societies. And then the positive occlusion should be of the internal carotid artery or the proximal MCA, M1. I think the M1 region, Leong already showed in his slide in his presentation. Okay, that's 3. The 4th one, the age should be above 18. The NIHSS score should be more than 6. And the aspect score as well should be more than 6. And finally, the treatment from the groin puncture can be initiated within 6 hours from the onset of the symptoms. So these are the 7 criteria set by the ASA, which needs to be met for stem retrieval endovascular therapy. Okay, this is just a comparison. So the top one, I took it from Quintinalis, the bottom one is from our CPG, and the right one is from RCAM Learning, our UK guideline. So just to compare, but actually as a whole thing, all 3 actually is the same. So more or less the same, because if you see the start of brain imaging from American Stroke Association is less than 20 minutes, whereas our CPG, door to CT is also 25 minutes. Even our Sungai Buloh guideline, also mentioned by Young, also was 25 minutes. And if you look at our UK guideline as well, it's 25 minutes. Finally, administration of thrombolytics, door to needle, less than 60. If you look at it, less than 60. Even UK as well, they follow the same time guideline, that are 60 minutes as well. So overall, there is no much difference in terms of the minutes between all these guidelines. Okay, for transient ischemic attack, the most common score we use is the ABCD score. However, one thing they noticed that it identified high-risk patients very poorly. So that's why they modified from ABCD to become ABCD3. ABCD3 became ABCDI with a diffuse weighted MRI. All this actually to increase the sensitivity of the score. However, it actually limits the usefulness in initial ED settings. So according to American College of Emergency Physicians, they actually advise not to solely use ABCD whether or not to discharge the TIA. That means don't use only the score to decide whether this patient can be safely discharged or not. However, even in the conclusion, there's actually not an appropriate algorithm to follow for an optimal approach on how to safely discharge on these TIA patients. So what they decided is, if they concluded based on their study here, if there's no any abnormality seen in the initial CT, no any abnormal ECG, no abnormal lab values, and no any signs of carotid stenosis or previous large stroke, then these patients, they advise them to at least observe in ED for 12 hours before they can be discharged from ED. This is what they concluded at the end. So this is the study that they made. Okay, so now my next 3 slides is basically going to be all the new recommendations based on our 2020 CPG guidelines. There are a lot, but I just took all the new recommendations. It's important for me to highlight here in my presentation for today. So one of the few things that they mentioned is, they say aspirin is actually not recommended as a stroke prevention in elderly, diabetics, and other high-risk groups. And this evidence is level 1, grade A. And secondly, they recommend use of statins as a stroke prevention in older persons with less direct evidence of benefit stroke prevention, and also primary prevention of vascular events with those aged 75 and above. And thirdly, we commonly see patients, they are on aspirin, but now they suggest us to combine both clopidogrel as well as aspirin in patients with minor ischemic or high-risk TIA patients for 21 days. What are the other things? Avoid very tight target glucose control. I think based on the presentation before this, they suggest us to keep the DXT between 6 to 10. So here they actually they said avoid very tight control 4 to 7, because we're just afraid if let's say the NPM patients and all that, they might become hypo. So try not to keep the glucose within the normal range within the first few hours of acute ischemic stroke. Okay. Secondly, patients who are more than 60 years of age actually can be considered for decompressive craniotomy in selected areas. This one, of course, we may need to liaise with all the other primary teams as well. But they say even if old patients, they can be actually considered for all these invasive operations. Okay, and thirdly, this is one of the studies which was done for elastic compression stockings. They said actually it should not be used as a DVT prophylaxis. There were a few trials done before this. One I read was the CLOTS trials. So based on this trial, what they found that those patients who were on elastic compression stockings, they had skin complications after being put on these stockings for a few days. So what they suggest is to use intermittent pneumatic compression instead of elastic compression stockings in this patient, because they found that these patients who use IPC has a less complications compared to those who are on compression stockings. Okay, and thirdly, study shows that actually there's no much benefit using unfractioned heparin or low molecular weight heparin in immobile patients. So this is basically just level 3 study only, grade C, so but it's not well established yet. So we don't really serve Clexane or any heparin for all stroke patients. Okay, I think this one we already established. They suggest for MECC to have a stroke-ready hospitals, recommend you have a local regional stroke referral system, and then make a decision from the PhD to ensure that treatment window is within 4.5 hours. I think this one we already have our own stroke hospital here, so I think this we have already achieved. And this is the next one. So as you all know, we only thrombolize if the patient comes within 4.5 hours. But if let's say we can actually perform a CT perfusion after the CT brain, actually we can extend the onset of 4.5 hours up to 9 hours actually, if there is a presence of a significant penumbra core mismatch. So if let's say with the CT perfusion there is a sign of penumbra core mismatch, then if let's say the onset is already more than 4.5 hours but still within 9 hours, they can still be given the treatment. This is based on our CPG's guideline. Okay, I think the next line Leong already explained. So the one of the other options besides alter place, we have a connector place. So this is the dose same as mentioned. Okay, next one is for the endovascular thrombectomy. So all these are level 1 evidence with grade A. All these are new recommendations in our latest guidelines CPG. So what they suggested here is for those with large vessel occlusion, especially in the proximal MCA, M1 and M2, presenting within 6 hours, EVT is indicated for this kind of patients. And for those who arrive after 6 to 24 hours, if there is still evidence of large vessel occlusion, they can still go with this EVT procedure as well. Okay. So what about drip and ship? Drip and ship basically means we thrombolize the patient first and then we proceed with thrombectomy. So for those acute ischemic stroke patients who present within 4.5 hours and eligible for RTPA, they should be considered for thrombolytic therapy prior to EVT. Meaning to say within 4.5 hours, thrombolize them first and then proceed with the EVT procedure. Okay, so for those patients undergoing this drip and ship, there should be no delay in proceeding to EVT to determine the clinical effectiveness of the alter place. That means if let's say we already started the alter place, no need to wait until we see the efficiency of the alter place in the patient. We straight proceed with the thrombectomy procedure. So all these are level 1 grade A evidence based on our CPG. Okay, so the other things is for older person, like I said, they should benefit from this intravenous thrombolysis. I think if our Sungai Buloh guidelines up to 80 years of age for intravenous thrombolysis. So until 80 years, so if let's say patient 70, we cannot straight say that they are not indicated for thrombolysis. So always see their comorbids, premorbids and all that and decide on that. Okay. So besides that, they also for those patients or AF patients, they prefer a direct oral anticoagulant such as dabigatran and all that over vitamin K antagonist and aspirin in this kind of patients with a previous history of stroke. And those patients with a Charcot score of more than 2 for males and more than 3 in females, they also prefer this oral anticoagulant compared to warfarin and other sorts of anticoagulants. Okay, so yeah, that's about it for my presentation today. Thanks a lot.
Thank you very much.
Okay, thank you very much, Karthik and Leong. Okay, do we have any questions from the floor? Any questions? Questions to Leong and Karthik?
Any role for aspirin for prevention? You check the AF patient, right? AF patient indeed. Any role to start aspirin as prevention? Because here we put oral anticoagulant.
But I think wrong because oral anticoagulants are also expensive. That's one thing. So if indicated, I mean, if in this setting, I wouldn't like starting aspirin first. Because like I said, oral anticoagulants are also expensive. So you can't start in all patients. But if indicated, if like I said here, they say aspirin is not as a primary prevention of stroke. We don't use aspirin. But for those who have already been diagnosed as having stroke, if indicated, we can start with aspirin first.
indicated for those who are more than 70. All right, yeah, that's right.
This was stroke prevention. Yeah, it's a stroke prevention.
So you want to comment on that? Is what you mentioned? Your answer, right?
The one I mentioned is to serve in those already diagnosed with stroke. But for as a stroke prevention, then of course I'll follow what I mentioned. I won't serve the aspirin.
I think aspirin now established no role in prevention during stroke AF. But if the aspirin has an indication for other conditions like underlying IHD, yes. But despite aspirin alone, we think that it can prevent stroke in the AF patient. So there's no role because it only increases risk of bleeding.
Alright, actually, first and foremost, I would like to congratulate to Group CN for the very, very good detailed presentation. And I can guarantee you that kalau you nak pergi masters exam final year, you baca ni dah cukup pas. Itu sebab you kan Anas. Betul tak Anas? Okay, it's part of the OSCE questions, right? Betul? Kita tak ingat? Right. It's for maybe Anas want to share something, your experience. What are the questions pertaining to stroke? Ingat tak soalan apa yang dua? Stroke.
I think yang pasal stroke tu, I tak ingat lah keluar KFQ atau my MCQ lah, tapi it came out in OSCE. So first part, of course, we will start with examination, then after that, then move on to asking some questions lah. So I think examination, I present kalau among us, kalau I tengok tu bila I tanya neuro examination findings kan. So most people diorang say very surface ataupun incomplete lah. Actually kalau kita biasa buat neuro exam, you can complete everything within 10 to 15 minutes tops. Tapi kena biasa buat dan kena tahu cara nak buat yang cepat, continuous, and then supaya kita tak forget lah all the nerve to be examined. Okay? Itu number one. I think we can improve on that. And then yang number two, with regards to OSCE, I think the questions asked is, so they should CT brain, then ask us to interpret the CT brain. So of course, if there is any obvious infarct, you will see. But then if there is very early infarct, what you want to see again. So jangan lupa lah, one of the earliest findings of CT brain in the case of infarct, it can be normal. So we have already mentioned pasal yang dot sign, dead sign, etc. kan. Tapi at the end of the day, does the CT brain correlate with the neurology? Kan, betul tak? Sometimes kita ada that old findings, ataupun kita ada silent infarct, which means appear on CT brain, but it doesn't manifest clinically. So if it doesn't correlate dengan stroke, with the patient punya acute presentation, then the CT brain doesn't say anything, doesn't add much. So at the end of the day, it's the patient punya clinical presentation lah. Then after that, they went into management of the hypertension prior to thrombolysis, and then one of the theorized question kita orang among ourselves lah, if in admin question is how do you improve you punya department in terms of stroke thrombolysis kan. So I think ours tu is a good one because tak semua hospital ada this stroke thrombolysis. So those yang master tu, I think that one can be asked admin questions lah. Jadi macam ada miss stroke for thrombolysis kan. Then the next question will come is how do you improve you punya department to catch all these cases and avoid missing out cases of thrombolysis. I think itu saja. And then one more thing, I think yang tak mention tu, what are the cases which require neurosurgery referral in the case of stroke? Okay. So this is which stroke cases require neurosurgery referral?
Patients that need surgical referral.
Probably those with large vessel occlusions leading to like increase in ICP symptoms, like herniation or increase of hydrocephalus and those kind of symptoms.
Kalau macam dia tanya tu, what do you mean by large MCA?
Means
Based on CT, I think based on CT findings, they got some mentioning. I forgot the term.
Ah.
Yeah, but they got, I think it's like very regional swell, edema, large, also that one is one of the indication, and also the midline shift is one of the indication.
Itu by that time it's quite obvious already, right? So macam I think kalau you pakai aspect score, you boleh pakai macam 6 or less, kan? Ataupun more than 1/3. Any cerebral stroke, any temporal lobe stroke, any hemorrhagic infarct. Sebab tu semua why cerebellar dengan why temporal specifically? Apa? Because diorang confined in a small space, kan? Atas tu dia ada yang macam non-expandable meningeal fold, tentorium cerebellae, etc. tu. So kalau dia swell swollen up over there, they have nowhere else to go except down. Betul tak? So they want to require early neuro intervention. Ya, itu sajalah untuk kan. Thank you.
Okay, thank you, Anas. So this is what we'll be emphasizing every single day. So whatever it is, when it comes to patients with stroke, your your physical examination and your clinical findings will be paramount over CT. CT is just to confirm your examination, your localization, and that is also used to determine whether it's like an infarct or if it's a bleed. So whatever it is, get your physical examination done, and your central nervous system, your cranial nervous system, and your cerebellar examination. So make sure your neurological examination is complete. Then only you can localize. Once you can localize, then you can confirm with your CT scan. Okay. Any other questions? Any other questions? Yes. So I do have a few questions here. For Leong and team now. Just now, besides Cincinnati pre-hospital stroke scale, so you did mention something about Rozier's score.
Rozier.
It's a score which I'm not familiar with. Would you kindly elaborate? How is it better in terms of detecting stroke in BFAST than over BFAST?
Oh, comparing to BFAST.
Saya rasa macam baru juga kan. Mungkin Dr. Su pernah baca.
Same.
Essentially, the big brand sama macam faster. It just want to add the component single so that to exclude the possibility that the paralysis and all that, syncope, the advance, and all this kind of. So why we are alert that these are proceeding on ischemic stroke to the thing of figure of the SAH or some cardiac syncope. So any of these
Untuk dokter ini.
Next page.
Okay, I have one more question, probably this one for our masters, our vocab trainees to answer. What would be your approach if you have a patient who presents with a simultaneous acute stroke and acute MI, and you have already ruled out aortic dissection? And bear in mind, these two conditions are time dependent.
Oh, easy question.
How will you approach simultaneous acute MI and acute stroke? You dah rule out aortic dissection. How will you approach? So what we do was we apply you need to PCR connection to the MI. What we do is we can make it for the patient and then we put the USP on the side. Any other input?
But unfortunately, because this patient has stroke and MI, and most of the center we don't have they can have a need for the stroke. So we can wait and await the
Actually, the approach to this situation is still very controversial because there's inadequate evidence to support any type of treatment strategy. Tapi based on the latest AHA guidelines, they recommend that if you have a patient who presents with simultaneous acute MI, acute stroke, you thrombolize for the stroke first, and then you proceed with PCI for MI. So the bottom line is do not delay thrombolysis for stroke. But this is just a recommendation, it's not a hard and fast rule. So whatever your treatment strategy is, you need to weigh risk and benefit.
What they call cardiocerebral syndrome. So cardiocerebral syndrome. So it all happens because of the heart yang develop MI, and basically there's quite a thrombus in the coronary vessel and in the brain vessel. So there are lots of case studies which have been done by orang-orang Barat. So what they did was the orang settlekan the brain first, right? So they give out the place, right? According to post-stroke neurology. And after that, they proceeded with PCI. Yeah, so straight away. So maksudnya kalau let's say kalau kita ada PCI sample, so we analyze the brain, and then we arrange for PCI after that. Yeah.
for the stroke is lower than the heart.
Yeah.
So thrombolize the brain, subsequently you can refer for PCI. Sometimes you thrombolize for the heart may be not always right, but it moves away.
You can read up on cardiocerebral syndrome, it's very interesting. Dia akan cakap pasal EF, how EF will develop in cardiocerebral syndrome. It depends on the region of the hemisphere that is affected. If it's the right side, they control the sympathetic, the left side of the hemisphere will control the parasympathetic. So that's how EF happens. At the same time, so basically you will get a stroke, you will get an MI and EF at the same time. So tiga benda at the same time. So it's cardiocerebral syndrome. Okay. Soalan lagi, kita boleh tanya kepada siapa? Tadi Kartik did mention something about Kartik and Leong alteplase and tenecteplase. Which one is better? Which one is better? And I think which one is better in terms of neurological function improvement and the risk of bleeding? Which one is better? I think boleh define bleeding juga tu. Define bleeding.
If not mistaken, the request actually higher incidence of bleeding, but compared to the selective request, it's actually same to the efficacy, the MRS for after 90 days.
In terms of the MRS score, if I'm not mistaken, the last time they did a trial on it is the same actually. No efficacy is the same. But in terms of bleeding, alteplase is actually higher risk of bleeding.
Yeah, so alteplase and tenecteplase, MRS itu adalah modified ranking score, lah, semua functional status of 1 sampai 6 terus lah, 6 je.
So they comparison between these two, they kata MRS sama saja, and the risk of bleeding is actually low in connected place. Reason being, kenapa they see is because of the mode of administration. Because satu bagi over 1 hour, satu bagi bullets. The risk of bleeding is low. So sebab tu dia letak. Tapi dia kata connected place is non-inferior to the outer place. Dia kata dia lah, it's non-inferior. It's not superior, tapi it's non-inferior. So you can consider connected place with one function called outer place. Okay. Tapi it's impossible for outer place to not be there because it's in the box. It's suggested like it. And suggested will be replenished bila dah dipakai. Any other questions?
Just a little bit about the NIHSS scoring. I know it's one way it's pretty easy to activate the stroke team when you call the operator and check out the activate stroke team. But this is not the case for other centers. In other centers, there are different ways of activating stroke team. So contohnya dekat ED-PPU app, if a patient presents with stroke, ED team have to do the NIHSS scoring, present to neuromedical lecturer or specialist. So you need to be well versed on the scoring. So kat sini you all biasa tak buat kan, sebab you all just refer neuromedical, but it's actually good to be well versed. Okay. Okay, I would like to echo what Dr. Indra mentioned. Sebenarnya, I think in Sungai, maybe PQM and Sungai is among the first to start stroke thrombolysis because Prof is one and initiated by Sungai, tapi biasalah Sabtuan ke saya kan. But anyway, the initial phase sebenarnya, all the NIHSS scores sebenarnya perlu dibuat di ED, tapi masa tu what we did is actually part of the credentialing, so we prioritize the pakar first. So once the pakar has started, because kalau ikutkan neuromed macam risau, kalau EP yang start the decision to thrombolyze, kalau ikut mana-mana sebenarnya to be faster, emergency physician can even start. Sebenarnya kat overseas, I think emergency physician started. So what we did was actually we credential the pakar. I think most of the pakar dah tak ada dekat sini. But anyway, it's a good thing that we start back sebenarnya because we are among the pioneer to start. I think it's good for you guys to know, apart from Rose's score, you all know the NIHSS score. And believe me, once you present very confident, the stroke team, even the neurologists will actually trust you, because the stroke team sebenarnya kita ada neurologist kat sini. Actually, the reason why we can do it is actually because we have neurologists and we have the neurosurgeon here. But of course, 2 years tu dah tak buat. So the reason why we enhance this very, very much is because we are going to be hybrid soon. So bila start tu kita tak nak lah baru nak introduce. Start tu you all dah boleh start terus. And probably facilitated mungkin by Dr. Su, the pakars and also the registrars or even master student, and encourage the MO as well to start to do the NIHSS score. Tapi don't delay your sending to the city to do this thing lah. So masa you all present, you all boleh start to present your scoring, and then tengok ada difference between you punya score and also the medical team punya score, and it can be done study. So once we prove that we are competent enough, I'm sure you are being trusted in majority of the times lah. Okay, so it can be done sebenarnya.
Sometimes among neurologists also may have a little bit of deviation. It's because it's very scientific and see. But the last time I attended the talk about stroke, one of the neurologists is dealing with actually the NIHSS score, you put 16 or 15, in not so much of difference. Yeah, it's just a scoring. So they are looking more for function after you thrombolyze, whether it improve or not. Sometimes the scoring for him, if let's say less than 4, so he will consider thrombolysis, although in the guideline is no. For example, I'm a pianist, tapi hand tu tak boleh gerak, only the hand. But to me, it is macam very severe impairment. But the score is very low. So that kind of patient, he will also thrombolyze that. Because after that, I cannot work already, I cannot play piano. Something like that. And also one thing to remind us that if patient comes before 4.5 hours of the onset, we activate the stroke team. And discussion with Dr. Ong before she actually asked I asked her whether, because of that, we want the plain CT brain plus the CTA. Right? So actually, she said we can actually ask for CTA. I know for some resistance among radiologists sometimes, but this has been discussed before this among radiologists, the neurologists. So we can request, unless the impairment is very little, very subtle, rapidly improving in your neurology, or you think it's just a lacuna stroke. But especially those 2 weeks ago, we had a stroke and thrombolized 3 weeks ago, and that one actually supposed to get straight away CTA, I think, better, because it came a bit late at nearly 4.5 hours, 4 hours or something like that. So in case it what CT brain and CTA, let's say got the lacuna, got a big large vessel occlusion, or we have exceeded 4.5 hours, and we can straight away go for thrombectomy. So we actually have to see the timing and the deficit as well.
Thank you, Dr. Su, for the very informative info. So remember, so whenever you get someone who comes in with stroke symptoms less than 4.5, so get your examination done, tak perlu cepat sangat, dan CT brain plain and CTA as well. Better.
Maybe got resistance, but if you try, because if you try, nobody will not us further. Because it's the same, and you don't have to further to ask for it.
Yeah, so kita order straight away lah, CT plain and CTA as well. So to expedite things. Okay. Soalan lagi, anyone?
So far, the stroke division office hour only, because like neurology team, they don't have a neurology team. It's all specialists and neurologists. So I think after this, when the manpower, they have their team, then we see whether we can expand service. Right now, anything, we also can call Dr. Ong if you need the neurology consultation.
Saya mau tambah sikit sebelum kita end our session. NIHSS score, it's very important, but it's going to be a medical conundrum bila kita dapat patients coming in with posterior circulation infarct. Kan sebab sometimes they will not come with this weakness and all kan. Kalau saya NIHSS score kan, kita kena tengok dia punya naik 10 saat tengok atau tidak kan, but sometimes posterior circulation infarct will not present with weakness. Right? So, but bear in mind that walaupun NIHSS score is 0 for posterior stroke, but the neurological and medical sequelae daripada NMS is very high. So walaupun kalau untuk posterior circulation infarct, the NIHSS score is 0, but the complications is severe as well. And so always get your NIHSS score done. And but when you suspect posterior circulation infarct, if your NIHSS score is 0, doesn't mean that no, it's okay, patient is okay. The complications will be severe as well. Okay. Any other questions? Tambahan daripada pakar-pakar, registrar, FRCAM students, houseman, MO, Anas, ada?
Masa saya lari balik, saya berjalan, memang ada few posterior circulation stroke, which was diagnosed as some other things lah. So siapa yang kenal Prof Kamarul, so dia memang neuro enthusiast kan. So dia macam datang untuk patient 5 minutes, okay, settle, so posterior circulation stroke. So macam okay, how lah kan, so dia cakap ada 5 Ps lah. So you concentrate on, first one is dizziness, then dysphagia, then diplopia, then dysarthria, then dysphagia. Some of these people may not have upper limb, lower limb weakness because it's posterior circulation. Okay. So if we can concentrate on those 5 Ps, hopefully we won't miss your posterior circulation stroke lah. Because management yang posterior circulation stroke ni can be quite difficult. Sebab kalau nak tengok NIHSS score ni, we concentrate only on anterior circulation. So yeah, so that one the management can be quite difficult. I think most of them tak thrombolyze, most of them akan require thrombectomy juga.
Another one thing is very case-to-case basis. Even if you have a very young patient, very active, suddenly they dapat a stroke, early wake-up stroke, please inform pakar so we can persuade the radiologist to ask for CT perfusion. It can be done. Jangan limit more than 4.5 early wake-up stroke, you tak buat apa-apa. Because other case lah is actually staff. That was before COVID. I'm not sure siapa yang ada kat sini. Staff, dia datang early wake up stroke. Very young, 30 something. Husband to one of the staff nurse, but of course at that point of time, I don't blame our department because it's more than 4.5, so we did not activate. But having said so, fortunately senang masuk ward. Biasalah kan, it's tough. When your relative masuk ward cepat, so in medical, they refer to Dr. Leong and they insist on CT perfusion, and it was thrombolized. So it's very dense. If I'm not mistaken, power was 0, but after that the power actually 505. 2 days later. So you can imagine lah. But that one is definitely pakar punya decision because we need to convince to get a situation play as senang kan. So please detect for us, then we'll do the next one. Yeah. Even stroke activation tu, ED role tu sebenarnya adalah untuk identify itu saja, identify activate whether they want to start or tak start tu is different story because it's a very good practice for us. Okay, right. So ada apa-apa lagi?
So houseman, you all dah tahu kan, we have that cut-off point and we want them to be thrombolized early. So let's say you're being sent to district hospital, patient baru je datang setengah jam lepas dia punya onset, actually sempat je nak sampai daripada HDP contohnya. So you can activate as early. Even if you are being sent to other department, it's not that it's not impossible for you to have patient yang dapat acute stroke masa dalam ward. So you can activate your medical neuromed team bila you dapat those kind of patient. Maybe you are in surgery ke orang tu menguasai.
Nothing to do with the CMEs. I think majority of you all dah just this one is regarding admin. Just to enhance, this is something that we hate to do, but for the benefit of teamwork of the hospitals, I think majority of you all dah dapatkan whatever WhatsApp that I've given, and then the pengarah suddenly give a letter insisted on certain things. Yeah, so this one is actually, of course, we try not to compromise our service, but at the same time, we'll try to do mapping between Dr. Alex, me, and also Dr. Zhu, and we'll see what we can do because sebenarnya kita akan ada a few more MOs coming, and then the master student coming. So during this very critical 2 weeks time, but I'm not so sure how long those who will be posted in the medical ward, even dekat medical pun they insist that they start to do calls if they want to do any more shift because kalau dekat ward, kalau dia buat shift, they need more. So even they have reduced, they have even tried that. I'm not so sure why suddenly a lot of surat transfer diarahkan keluar lah. Basically maybe the contract resign, kita pun resign. Tapi because the issue for Sungai Buloh is actually we are managing 2 hospitals with 1 hospital staff. Here we have ourselves and also PTKM, but actually PTKM has 0 staff. So it has to be distributed, but at the same time we are trying our best to ask for more MOs, and then since we all dah ada houseman, so houseman akan jadi MO floating, so you can imagine houseman the moment the next day you jadi MO you dah take full responsibility, so better learn. You can do a lot of blunders in during houseman, but not during MOs. Because as a houseman, you are responsible, but you are not liable. When you become MO, you are responsible and you are liable. So you tidak boleh dipersalahkan. tapi dipertanggungjawabkan, kalau tak maksudnya. So we really need you guys, but of course as a MO, so nanti the moment you dah jadi homo, kita panggil homosexual, homo is houseman medical officer, transition time, so that's when you start to practice. No more, tak boleh. Okay lah, sorry. Okay. No more. So I hope that you guys understand. This is something that we hate to do, but it's actually for the benefit of the work juga. Sebab kalau kita tak buat, Misha akan stranded kat ini, tak boleh hantar pergi work juga. So it's about the same lah. So not only us, all other medical fraternities, all surgical fraternities are also affected. So that's the thing that I want to explain to you guys. Yeah. So I think lepas ni break makan sekejap. Kau jumpa terus? Okay, jumpa terus. Boleh stay back with the pakars.
Namaskar. Dengan sejaja. Dalam masa pengajaran boleh apa kita punya dengue course, dengue webinar course will be on the 8th of December. Kepada siapa yang belum daftar lagi, sila daftar. Sebab dia free je. Akan ada Dr. Khalid, saya, Ungkasen, semua adalah. Kalau misalnya kalau penuh, kita masih ada YouTube channel kita dan korang boleh tengok nanti. Nanti kita akan pasang di green zone, kita akan project untuk semua yang tak dapat register untuk tengok. Okay, so it's going to be on the 8th of December daripada 8 pagi sampai 4 petang. Okay, terima kasih.
FRM trainees and pakar lain to stay back and relax to the student. Thank you.
Saya bukan